I am so excited to be hosting this discussion today. I'm Virta's Chief Medical Officer, and I'm trained in obstetrics and gynecology. So this topic has particular meaning to me from a professional perspective. Clinically, menopause significantly influences metabolic health as hormonal changes, particularly the decline in estrogen levels, influence a host of metabolic processes, including adipose tissue deposition, insulin resistance, carbohydrate metabolism, and other events. These changes can affect body composition, lipid metabolism, glucose homeostasis, and overall metabolic risk. The health benefit space has seen ample discussion in recent years about the need for benefits focused on fertility, pregnancy, parenting, but menopause, on the other hand, seems under-resourced. And so I'm so excited to welcome two fantastic experts to the stage for this discussion. Dr. Jessica Shepard is a board-certified gynecologist and women's health expert who specializes in menopausal health. She's also the chief medical officer of HERS, and has a holistic practice in Dallas. The release of her book, Generation M, last year created more buzz in the menopause world and was featured on the Today Show, Good Morning America, and Live with Kelly and Mark. Dr. Grishma Shetty is board certified in internal medicine and endocrinology. Dr. Shetty is director of quality and safety here at Virta Health, and prior to joining Virta, she was on faculty at the Harvard Medical School, where she directed the combined Joslin Beth Israel Deaconess Endocrine Fellowship Program and co-directed the Asian American Diabetes Initiative. So let's jump right in. Metabolic health isn't typically linked to conversations about menopause, but both are hormone-driven. Jessica, can you set the stage for us on menopause and tell how these conditions are intertwined?
Yeah, I'm so delighted to be here and to be able to share this information on menopause when we think of metabolic health, because for so long, menopause kind of was the taboo topic. And so I think that when we look at menopause, typically we see it as a very reproductive type of transition or something that happens or occurs in the body. But what we do know from data, evidence, studies is that it really is a whole body experience. And that has to do with the decrease in estrogen. And estrogen is not only just for reproductive, you know, actions within the body. It really has a lot to do so much more with other end organs that impact metabolic health. And so that's why for so long, women felt that they were unheard or unseen because they would start to have these changes, not only with symptoms that typically come with menopause, but the metabolic features, what they were seeing as far as their weight, or we even see a comment here that came in as soon as we started the session on becoming pre-diabetic into the diabetic phase. And so I think that we kind of maybe didn't have everything that we needed to collectively put this together as a whole body experience. And I'm so glad that we are on that phase now where we can at least allow women to understand what is going on with them as they go through perimenopause and menopause as more of a metabolic feature than just an ovarian feature.
Thanks. Grishma, over to you. Talk a little bit about what happens to metabolic health as women age. What's it like before and then after menopause?
Sure. Well, first, thank you for having me on this panel. Delighted to be here with you and Jessica talking about metabolism and women's health, things that are very close and dear to my heart. So first, there's a significant change in hormonal status when you go through menopause. And as Jessica alluded to, the drop in estrogen is a fundamental step. And this drives a lot of the metabolic changes that happen. It contributes to sort of reallocation of fat and increased fat deposition in the body. So not only increased total body fat, but actually allocating it to what we call the abdominal or visceral compartment. And that compartment is where fat tends to be more inflammatory and drive a lot of the metabolic dysfunction we see in metabolic syndromes and diseases such as diabetes or fatty liver disease or MAFLD as it's called now. So this redistribution of fat to the central compartment makes a big difference. And that also creates what we call insulin resistance, where the body's ability to mobilize glucose appropriately, sugar, from outside of the bloodstream, properly and putting it in the proper compartments is meeting a lot of resistance. And this happens peripherally at the level of the muscle tissue. It happens centrally at the level of the liver. And beyond that, I would even say the estrogen plays other roles that, research has shown that it can affect your ability to have earlier satiety. It actually impacts hormones called leptin and adiponectin and ghrelin. And these are all hormones that are related to satiety and appetite. So it could also contribute to that drive of weight gain. And finally, we think about, as we look at women's health in a holistic way, it's about metabolic health, weight changes, cardiovascular risk, which doubles after menopause. And then thinking about other aspects of life quality, sexual health, sleep, cognitive function. So there's a lot of things that interplay here, and it's a very complex system.
Thank you both for setting the stage here. Let's talk a little bit about the healthcare system. Why do you think it is that traditional healthcare approaches and the healthcare system as we know it sometimes fails to address the interconnected challenges of these two phenomena? And Jessica, maybe you take this question first, and then Grishma.
Yeah, I'll take a stab at it from the aspect of women's health. And, just someone who, as an OBGYN and really, focusing on midlife health now in my practice, is fundamentally women have not been included in research. Or when we look at how we personify women's health, a lot of it actually has to do with the reproductive phase. And so when you have that perimenopausal and menopausal aspect of a woman's life, there are a lot of things that weren't paid attention to, the interconnecting between metabolic health, looking at women as they're starting to get out of their phase of a menstrual cycle and what happens with them compositely from the body perspective, symptom perspective, emotional perspective. And so I think that there was a lot lost on outside of the reproductive phase. And, even from my training when I was going through residency, there was really so much that was unknown, even from a provider perspective, and looking at it as someone who's supposed to be, at the top tier as far as information on how to treat women in perimenopause and menopause. And it comes from two different perspectives. I think that the research really wasn't including women outside of the reproductive phase, and looking at menopause actually as a very sentinel event that happens in a woman's life, and all the things that come from the estrogen decline, and not just from an ovarian perspective. And then the other thing I think is that, when we look at the WHI study, that was more, we're probably more than 20 years from the WHI study, there was so much impact that came from that study that there was a lot that was dropped with it in order to just maybe the fear of, or the uncertainty of, and also some of the, the outcomes that came from that, which when we, did retrospective analysis of it, we did we realized that there actually was much more benefit to some of the risk that was portrayed to the public. So it comes from both the patient perspective of not necessarily wanting to discuss menopause, and then from a provider perspective for us in research and not really knowing the true data that surrounded what happens with estrogen decline. And so I think from both perspectives now, we are seeing that women are a little bit more inclined and in tune to hearing about themselves in this phase in midlife, but also in the research aspect, we really have come a long way from WHI in being able to present not only the benefits of estrogen on symptom relief, but also longevity, because we know that has such an interplay with metabolic system.
Yeah, that's such an important point. Grishma, go ahead.
Yeah, great response. I would just add that I think in regards to how our health system is not aligned very well in addressing this, I think we our health ecosystem is very reactive. And when you really want to think about metabolic health over a lifespan, you really need to take on a more proactive posture. And, there are often moments that are sentinel moments in a woman's life, whether it's the age she goes through puberty, how heavy she is at puberty. Are her menstrual cycles regular or irregular earlier on in her life? Does she develop gestational diabetes? How does she do with her interpregnancy weight loss and weight retention? And then, age of going into menopause as well, and severity of symptoms. So really, those are all discrete opportunities where we can reassess and recalibrate risk and come up with a plan. So I don't think we do that in sort of our reactive healthcare model. We wait for diseases to happen and then we offer treatment. The other piece is I think we underestimate our patients' abilities to understand their own health, and we don't give them the agency. And part of the problem is, when you take care of people with metabolic health in a fee-for-service model, that kind of proactive preventative care is not supported or compensated. So the whole model doesn't reward us if we spend that time with patients. We're rewarded if we get more patients through the door, not the quality of time we spend with them. So I think those would be the big things I'd call out and where we have a miss in our system.
Yeah, really, really important observations. The new intervention, it seems like, on everyone's mind are the GLP-1s. And in the context of weight gain being a accelerating typically for women as they age, it seems as though lots of women are turning to GLP-1s as a solution. So what are your thoughts on that? Are GLP-1s the answer? Are they a tool in the kit? Jessica, you want to take this one first?
Yeah, I love this one, being the chief medical officer at HERS, where we do offer a lot of GLPs. But even in my practice, this is something that as soon as they were on the market and I saw really the mechanism of action and understanding truly what was behind the scenes with menopause and what goes on with the decline in estrogen, I really think it is such a beautiful tool for us to have, because there is, again, we typically practice medicine reactively. And so in order for us to now get to women who are in that midlife phase and helping them understand, again, the full effect of what happens with menopause and the decline in estrogen, but also we do have an obesity, epidemic in this country. And so now it's kind of like compounded. We typically see, as women are entering in midlife, not understanding the complexity of the hormone changes, already possibly having an overweight or an obesity issue coming into that. Now we're kind of having this layer cake effect. And so it is very hard for women entering that phase, to whether or not they do hormone replacement therapy or not, is to understand, again, the fundamentals of why we're seeing weight gain. And so I think that, in my practice, typically I help people understand from the information gap what is going on, and then being able to offer them this tool in the toolbox in order to help them decrease the weight, not only for, the weight loss, which is still a great reason to use a GLP, but the comorbidities that are associated with obesity and decline in estrogen with menopause. So that layer cake effect is only going to be compounded, where you're going to increase the risk of cardiovascular disease, which we know that heart disease is the #1 killer of women, dyslipidemia, insulin resistance, and putting these all together, if we have the ability and we have the tool to allow women to get to this kind of health platform, or allowing themselves to feel that they are going towards a positive impact in their life, then I think that this is a tool. The thing behind it that I feel is important as well is to understand the lifestyle changes that need to be in conjunction with GLP use, because there may be people who do want to use it for a long term, but even in that, there still needs to be this foundation that's going on internally along with the use of the GLP in order to sustain and to get the best outcome when we optimize someone's health with using a GLP in menopause.
Thanks. And Grishma, maybe pick that thread up and talk a little bit about your point of view on the use of GLP-1s, and particularly the lifestyle modifications that you think are appropriate, that I think Jessica was alluding to.
Yeah, no. So, in any conversation regarding any prescription, and GLP-1s are wonderful medications, but there's always a risk-benefit ratio that you need to consider. So, on the benefit side for GLP-1 and the role, especially in postmenopausal women with metabolic disease, there's definite data to support that GLP-1s actually do, in real world and clinical trials, result in weight loss. And actually, the fat and the adiposity loss in women is greater because women actually have greater fat mass than men. So it is really robust in in terms of that result. And, when you lose fat, you actually improve the insulin resistance, which drives a lot of the metabolic dysfunction. So there's a lot of significant upside and potential. But I would caution that, again, we know that the GLP-1s are not sustainable for a large portion. And in fact, women tend to have more GI and nausea and GI intolerance of these medicines. It may be related to gastric motility. It's not 100% clear why. Might be dose related. So again, sustainability, if it's an issue, we really want to make sure that we can optimize these drugs in a short term, maybe to trigger some lifestyle changes. And then if folks can't stay on it, help them have a way to get off. And the other piece I always worry about, because again, as an endocrinologist, I worry about women's bones and their bone health and muscles and falls. So as we get older, there's this thing called sarcopenia where we lose our muscle mass. And this happens every decade after we turn 30. And for women, it really accelerates after we lose estrogen and menopause occurs. So really thinking about that and being mindful of the whole metabolic package is really important. So to address this in terms of lifestyle changes, obviously the things that we do at Virta, where we focus on nutrition and macronutrient content, really optimizing that is very powerful. And then the other piece is the exercise. Women face an exercise gap, and that gap actually starts in adolescence. Girls start dropping out of sports, and then professionally in their 20s and 30s when they have pregnancies, there's a hit there. We decrease our exercise. The average working woman gets a less than an hour less than men in exercise every week. So, and this is compounded, the types of exercise we do. We don't even do the resistance training as much as we should, which could really benefit us. So really looking at it holistically, along with the medication, diet and exercise is critical.
Yeah, such an important point. And I think it's a through line in today's conversation from Dr. Attia through to this conversation. Jessica, you have a lot of experience with management of menopausal symptoms, but also the issue of weight gain and the use of GLP-1s in your practice. Talk a little bit about how you think about the GLP-1 medications before and after menopause. Is it a continuum? Do you think about it differently? Are these lifelong drugs, short-term drugs? What's your strategy?
Yeah, the strategy is not an easy one because I really love the personalization of holistic medicine. For each person that walks in, they're going to walk in with a different category of what is hindering them, what their past medical history is, or where they're trying to go, as far as like what their optimal goals are. And so sitting down with each individual that walks in and helping them understand where they are and meeting them where they are is probably the most important part of how I talk to patients and counsel them with management plans. Fundamentally, I definitely agree with Grishma is that the layer cake effect, there has to be a good foundation. And if there is no knowledge base behind what really is going to impact them from a diet and an exercise perspective, I think that could be a missing block in a lot of the healthcare that women get today, because there is so much that can be done on those fronts. And typically women are unaware of what they can do in diet as far as increasing their protein and their fiber and their vitamin D as they start to go through their 40s and 50s into menopause, but also that sarcopenia, especially if I'm going to put them on a GLP and going to have that impact of sarcopenia, which they're already having as well. And then compounded with the increase or the decrease in estrogen as well. So it's kind of like we have these things that just keep layering on each other. And if we don't pay attention to them, then I think that is my responsibility to let them know those fundamentals. Now, back to using the GLPs, I think that there are a lot of women who they're exhausted with trying, whether it was the diets or that whatever it was, not realizing that this was fundamentally something that wasn't their fault. And so there's a lot of work that goes into helping them understand that they can overcome it, but with that, understanding their kind of advocacy for themselves or the agency that they need to take when it comes to now lifestyle. Because as much as I love GLPs, at the end of the day, they are a medication. And so if we rely on them solely without giving, our patients the benefit of knowing what they can do in their lifestyle, if they choose to come off it, or if they happen to come off of it, or they don't stay on it for lifelong, my worry is that because they haven't created this fundamental basis of what truly can be their lifestyle and how they can improve their longevity, then when that is exited, then they may have that risk of gaining the weight back or increasing some of the comorbidities that were kind of stacking against them due to aging and a menopausal impact as well. So it really, to me, I say this is a marathon, not a sprint. And so starting out that process means, what are we going to do today? But how are we going to create continuity and sustainability that will get you 20 years, 30 years living your best life? And sometimes that is much harder for us to conceptualize because we live in a day and age where we want something overnight and we want it to be fixed by the next day. Is that our lives and the way that our bodies function really is a marathon and not a sprint. So I think starting out with fundamental information education, personalized to that person, is the best way to do it.
I hear you, and I hear emphasis on a individualized approach and a comprehensive approach. It isn't one size fits all, although the medications do represent a new tool. Grishma, talk about other ways of achieving control of metabolic health. And we've had a discussion about GLP-1s. What are some other ways of thinking about this multifaceted issue?
Yeah, I think it makes it really important that this sort of the longitudinal aspect, and I like that, and I use that one all the time, the marathon of like a woman's health and reproductive health. There's these milestones throughout their life, which I mentioned earlier, whether it's when you get your first period and what age it was, menarche, then what your cycles are like in your young adulthood. Do you develop gestational diabetes? There are all these opportunities throughout a woman's journey. And so sort of really empowering both the clinician and the patient. I think that means better training for clinicians and really keeping that conversation going through just routine preventative care visits and sort of reassessing it, especially at those, vital signs of like menarche, pregnancy, and menopause. But even in between those visits, just keeping the conversation going and assessing, and then really informing the patient what their risk is, looking at their own genetic risk, whether they're from a higher risk ethnic group, and making sure we're, modeling risk reduction based on that as well. So, and a lot of these things begin before people have disease, right? So in metabolic health, it's not an on-off switch. You don't all of a sudden one day have metabolic dysfunction. There is a slow progression. And so really being aware of that and moving the patient right and recalibrating. So if someone does develop gestational diabetes, for instance, because that's mid reproductive health life, making sure you're having the conversation. Hey, your risk for X, Y, and Z is this. Let's focus on doing this in the next couple of years so you can reduce your risk. So being very proactive. And then making sure that we have resources to higher risk populations. And I think this is where what we do at Virta is so powerful because we're a remote continuous care company. I mean, the outreach I have now is so powerful. I can reach people all over the country. And that to me is very joyful and empowering for me as a clinician. And then the last group of speakers spoke about AI. I mean, that is going to be exciting. I don't think AI is going to replace us. I think they will help us do a better job. They will help outline these key markers and like alert us to do better. So I think these are tools that are evolving and are going to be able to help us do a better job with this. And then research. We need to invest more in women's health research. I mean, it's always a miss, even in 2024, 2025, there are studies, cardiovascular studies that are released that less than 20% of the participants are women. So that's a problem. So we need to fix that.
So thanks. Really important points and also context. Speaking of research, and I want to change the subject here. I want to talk a little bit about hormone replacement therapy, HRT, estrogen replacement therapy. I'm dating myself here, but I was a resident when the Women's Health Initiative study came out, and honestly, the conversation about this topic became incredibly muddied for 25 years. So, Jessica, just give us a little bit of history here and then
Yeah.
set us straight and talk a little bit about the state of hormone replacement therapy and its role in this conversation.
Yeah, the beauty of research, obviously, is that's how we progress in medicine and science. And this was a profound study that was done, one of the largest studies in women when we look at how many women were included in the study. And the actual primary reason for the study was actually looking at cardiovascular health and the use of hormones. And through that study, there were some things that came up from risk, and one of those was breast cancer. Unfortunately, how media took the results and kind of put that out to, the population and the community was actually not beneficial, because from that, what we took was just a whole complete negative uh, kind of perspective on hormone replacement therapy, and it literally crushed it overnight. And fast forward now is, doing the due diligence and looking at the study and retrospectively looking at what was done and why these outcomes the way they were, is slowly we began to realize that there actually was so much benefit to the study in understanding hormone replacement therapy and how it can actually benefit a woman's life from symptom resolution, but also decreasing a lot of comorbidities such as colon cancer, osteoporosis, dementia, and that is going to improve the longevity of a woman's life. And women typically live longer than men, but what they do is they live poorer health in those years that they are living longer than men. And a lot of that has to do with estrogen decline at that transition in a woman's life in menopause. And it kind of creates a cascade or a domino effect for some of these other comorbidities. And so now, fast forward, where we are at a point where we truly understand how beneficial hormone replacement therapy is re-entering this phase, and making sure we don't trigger any alarms or allow people to feel unsure of why we're, giving HRT. So it has to be a slow entry. And that's what we're doing now, is allowing for providers to understand what the research was and what the data is, because that's important for providers to have that information to convey to their patients, but also for the patients to understand, yes, this is something that did have a very negative title for very long. This is how we want you to view it, to understand it. And so those are actually two very different messages, because one's going to be very scientific and high yield, and the other really needs to bring reassurance, but also personalization, which is what we've talked about again, and how it can impact that certain individual who's looking to HRT. So when we think of estrogen, progesterone, and testosterone, which is a beautiful, addition to hormone replacement therapy, I think that every woman can see the benefit in taking hormone replacement therapy. And the one thing that I would say is a lot of patients think that hormones are medications. And how I like to position hormone replacement therapy is, this is something that your body was already making. And now in the decline, going through perimenopause and menopause, we are trying to give you a level of hormones that your body already was producing in order to offset disease, in order to decrease symptoms, but also to impact long-term diseases that come with aging, to offset some of those. And when you think of women specifically and how they die, usually is going to be they fall and break a bone. So that's osteoporosis, which is impacted by decline in estrogen. Heart disease. We know that there are estrogen receptors on the heart. And then last but not least is dementia. A lot of cases of dementia, more women are apt to have dementia than men. And so even with those three things, if we were to categorize that, what that means to a woman as she, gets into her older age, and impacting it with hormone replacement therapy, I think it is a conversation that needs to be had. But also, no one out there should feel that they have to do it. It needs to be something that they want to do and feel comfortable with doing.
I think such helpful information, and it fits nicely into the context of what we've been talking about today: an individualized approach to care, shared decision making
Yeah.
between the provider and the patient, and care over the long term, because it's not a short term issue. This is a lifespan or health span set of conversations. let's broaden it out just a little bit and talk about breast health, bone health, sexual health. What are some other ways that the topics of or the interventions of nutrition, hormones, um, GLP-1s are influencing the holistic health of women as they age? Jessica, you want to pick that one up?
Yeah, definitely. I think, women come into the office and they have all of these complaints that span sleep, decreased libido, decreased activity and energy. And so many are surprised to hear that it has to do something with this transition. And it's not just estrogen. I think that there are a lot of other things that play into why women feel this way. And so the first thing I do is like to validate and reassure women, because for so long it used to be, oh, yeah, this is what happens, just deal with it. And so I think that we have so many tools now as far as lifestyle factors. We talked about, how to restore sleep and how important that is, again, to decreasing comorbidities, but also with diet and exercise. And now putting in hormone replacement therapy now that we're at a place where it can have that positive light, and then GLPs. So imagine the toolbox that we have and everyone coming in with these individual complaints and how they're struggling in life and obstacles that they may have. The ability that we have as physicians and providers to meet those needs at an N of one, I think is where the future lies. Just as we talk about AI, I think that we have this ability to now reach people with so much more than we had before with better data. And also, we have better studies that are actually looking long term. That's something that we never used to really look at in the past. It really was to have a solution for a problem at a time and to get rid of it, not looking at long term impact and effect. And now, as we look more into well span, as you mentioned earlier, Adam, and longevity, I think if we can change the perception of how someone enters into their health, being proactive, but also looking fast forward into how do I want to age into my 70s, 80s, and 90s in a way that I can deal with now and address now. We have all the tools. And I think that now that we have the impact of virtual health and telehealth, I think that that also is another factor into the resources and access that we have for people to make sure that this composite of what their life looks like now and also in the future.
Thanks. One of the comments that I really appreciated from the prior session was the comment that it's not that AI is going to replace professionals, but professionals who use AI will replace professionals who don't. And I think that on some level applies to the way we think about caring for patients.
I actually
I
heard
want to
that
sort of
and I wrote it down because I was like, I'm going to use that one. That was a good one.
So we've established a lot of connections and through lines here, and I'd like to sort of switch the conversation to talk a little bit about how we, as an industry, as a healthcare industry, can improve the way we approach women's health and metabolic health. Grishma, I know you've thought a lot about that as Virta's Director of Quality and Safety, but maybe talk about how you think the healthcare system can change this conversation for women.
Yeah. So the system, I think as is now, I've mentioned, I think the key is we really need to be thinking more proactively and longitudinally, and even with the conversation about hormone replacement. It needs to be a very personal discussion with your provider, looking at your individual risk benefit ratio, what prior medical history you personally have had, what kind of diseases exist in your family, and what your sort of comfort level with risk benefit ratio is moving forward. So, a woman early menopause is also very different than a woman who's later menopause, who's been in menopause, postmenopausal for, 1 or 2 decades. So really, in endocrinology and metabolism, the age that you're addressing is very important, because what may be right for a 20-year-old will not probably be right for a 55-year-old, and certainly will not be right for an 80-year-old. So, really being thoughtful and mindful of thinking where we are in our health journey and what our goals are and how we maintain the level of quality. I think front and center is quality of life. And I think, as women age and live longer, the goal is not just lifespan, but health span. I think Dr. Attia has said that earlier this afternoon. So I really, that really resonates with me. And so, listen, I would love to be a dynamic 90-year-old, but, not kyphotic and like have strong bones and be able to be cognitively intact. And I think looking at those goals and trying to track along those metrics to do that, I think is key. And again, I think this is a model of care that requires investment that typically isn't seen in a fee-for-service model of healthcare. And I think that's a big societal change that we need to think about for women's health and preventative health in general.
Thanks so much. Jessica, thoughts on how the system can change to address these topics?
Yeah, that if we had another hour, I would love to give the full answer. But I think they're actually, it's multifaceted when I think of the answer, but I put some responsibility on us as providers in health in the healthcare industry is there needs to be a reshifting of how we think of the patients that walk in. I think there requires a change in the emotional health and aspect of, and especially women, because, I'm an OBGYN and see women is there is so much of an emotional health aspect that goes into this transition. And many times that is not addressed. The other part of this is to make sure that we are addressing the toolbox from different perspectives of every person that walks in. Everyone who walks in, coming in for hormone replacement therapy, thinks that it's just like one dose or one way to have it. And when I go through with them and the complexity of what they can take, why they should take it, what dose and what modality, and all these different ways to address it, they are actually quite surprised at the offerings and the modalities that are available. And so I think even as providers, we also need to understand the complexity and the range in those modalities and doses and adding testosterone or adding a different form of estrogen. And I think once we get there, and I do believe that we will, I think that people can understand that this transition is not as scary as we have put out before. And I think that that's, if I always say this, if I were a screenwriter right now, menopause, it looks as a horror story. Like no one wants to go into that closet to see what's going to pop out at them. But if we change the narrative in what this transition is, being proactive, allowing women who are in their 30s to understand that perimenopausal phase that's coming, so it's not this hard wall that they're going to hit, is that actually can become more of a comedic love story for people to go through. Because, what better way is to kind of laugh as you're going through something, but understanding that it is a process in where you're going to reveal so much more love for yourself as you go through menopause. It sounds very, very kind of woo woo, but I do believe that women, when we reach this phase, have been told whether it's in their career, whether it's in their relationships, in their family life, that kind of life is just like on a downward trend from there. And I really would love to change that perspective for women.
That's a great set of analogies. So this is Verda. This is Moonshots. We're all about innovation, thinking big. Grishma, starting with you, when you think about the best that's out there, the best ideas that are out there, maybe even the best ideas that aren't out there, what do you think we should be doing or could be doing to support women as they age from a holistic perspective, from a medical perspective, from an emotional perspective? What comes to mind as an innovator?
The lifespan thing and sort of the life journey and the vital signs of a woman's metabolic health are so discreet. And I feel like it's a lost opportunity that we have such fragmented healthcare. Like we have the pediatricians that deal with them until this age. And then often they're lost until they decide they want to start a family. And then they go to the OBGYN. And later on, they develop a metabolic disease or menopause or osteoporosis, and they go to an endocrinologist. And so it's this sub-compartmentalizing and it's very disjointed. And I think this is probably in my dream world where you would link all of it. And I think this is the power of technology, universal, like a platform that shares your health information and your health journey one place, connects you to all your providers, a payer that's not just invested in you for 1 year, because 1 year is not enough time to see like the dividends of investing in good health, good habits. So really thinking about it sort of longitudinally, which it's probably not the most exciting answer, but honestly, I think if we could shift the model so that like we're able to integrate more of the aspects of a woman's health longitudinally and recognize that, support that, and reward that, I think it would drive a lot of results. I mean, a lot of this stuff starts in utero. Like a mother who has gestational diabetes that's not well controlled is already programming her female offspring in utero to be set up for metabolic disease. And then a teenager in puberty hits it, and then GDM, and then menopause. So it doesn't happen overnight. And so if we could better calibrate that throughout a lifespan, I think that would be a revolution.
It would be a revolution. Jessica, how about you? As putting on your entrepreneur's hat, your innovator's hat, what do you think we should be thinking about?
I think, going back to the AI and telehealth, just kind of where we've come actually in the last 5 years with transitioning medicine out of, again, just this transactional, go to the office, get that one problem taken care of, and then you don't have to follow up for a year, if not more, is that making it part of the relationship of one's life journey is the relationship that we have with health now, I would say is not very healthy, because we wait for something to happen and then we go. And so if we change the kind of the perspective of what is this health journey, what does it mean for my life long term? I think that the interactions in as far as quantity and quality, but also providing a foundation that doesn't even have to do with medications or disease. And so if that becomes more of the conversation and it's more interaction, more relationship, that's where you start to build more of the accountability, but also the way that you can take agency for yourself because you know what you're trying to prevent, you know how you're doing it, and there's someone who's able to track that. So even, in the day and age of wearables, I'm wearing an Aura and a Whoop, that's probably overkill. But with that, being able to track how you're sleeping at an N of one, what's my sleep habits like? Now, what can I do to impact that? Why is sleep good? And moving through your health journey in that way, I think putting all of that together, we really are at a stage in technology and innovation where we get to take more part in our health journey. And so taking away that I only go when I get sick, or I don't want to go to the doctor because I don't want to hear the bad news. I think if it became more of this relationship where it's a life journey and a transition as we go through each year and stage in our life, we would have much better outcomes. And I think that is possible with some of the platforms that we see, and obviously with Virta Health and how you approach patients, but the access and the resources. There's so many people who don't have access to healthcare centers in their cities, and we have health deserts. And so we need to do a better equitable way at how people are able to approach their health and the resources and access that they have.
Yeah, so important. So we are practically out of time, and this conversation has just been fantastic. But I'm going to wrap up with one really quick question, and then quick answers, please, from each of you. But you're speaking to a group of health plan managers, professionals, benefits managers. These are people who are making really important decisions for employees and members all over the United States. Give them some advice as clinicians, as experts, as innovators when it comes to taking care of the women among their workforce or their health plan. Grishma, why don't you go first?
Yeah, I think first, I think knowledge is very powerful. So, providing the opportunity to gain information about their metabolic health, to have appropriate access to screening, to support preventative care is critical. I know we're late a minute, so I could keep going, but I will stop. I think knowledge is powerful, and empowering patients to have agency is really important.
Jessica?
I would definitely say, and this is something that I've had to really work on over the last few years, is empathy. Empathy in hearing people's journey story, not taking that for granted and using that as a vehicle to change how the interaction or the relationship with the patient is. And it doesn't come overnight, but it's just with time that then they can lean in because they feel that, their provider is meeting them where they need and where they're at.
Thank you. Well, to those of you who've been listening to this panel, thank you for joining us. Dr. Shetty, Dr. Shepard, what a important and fantastic conversation. Thank you so much for joining me.
Thank you.
Thank you.